So the goals of this particular talk is to discuss some of the evidence in the literature, taking a look at the dose escalation for biologics in our psoriasis patients, and also thinking about combining biologic therapy with other types of modalities in these particular recalcitrant cases. So what constitutes non-standard or off-label dosing? Well, there are several things. Number one is we oftentimes think of dose escalation or intensification, and this is the area we're going to focus on today. So could you increase the dose of the medication that you're currently using, or perhaps shorten the duration in which you are administering the same dose? Or other types of off-label dosing obviously include dose reduction, intermittent therapy, or interrupted therapy, which I will not talk about today. So with regards to dose escalation, when we look at the literature, oftentimes it's reserved for patients with, for example, suboptimal response to the standard dosing. And with regards to the literature, there's a definition of partial responders and non-responders. And partial responders are typically defined as those patients who have had at least PASI 50 response between 50 to 75 with regards to their PASI response. And then non-responders is typically considered as patients who have had less than 50 in terms of their PASI response. In clinical practice, we know that when a patient has 30% response, we still consider them response somewhat. But in terms of clinical trial definitions, typically non-response are those with PASI 50 or less. So I just want to make a small comment here is that as we know, in the United States, the FDA is a regulatory body, but different regulatory bodies exist for different countries. So the dosing could be different depending on where you live. In the United States, the FDA-approved dosing for etanercept, for example, is 50 milligrams twice weekly for 12 weeks for psoriasis, followed by 50 milligrams weekly for maintenance. So having defined that standard dose, when we talk about dose escalation, are any treatment modalities that are different from that? So the largest study that have looked at dose escalation is this particular trial by Leonardi et al., where they looked at 912 patients with moderate to severe psoriasis. All of them at first got 12 weeks of maintenance therapy, actually, 50 milligrams once weekly. And after that, the responders essentially maintain their weekly dose. The non-responder definition here is a little bit tricky in that clinician judgment can be part of it as a non-responder. So the non-responder here escalated their dose to 50 milligrams twice weekly after 12 weeks. So what we see here, as you can see here, is the non-responders, after 12 weeks, they can essentially escalate to 50 milligrams twice weekly. As you see that among the non-responders, despite of this dose escalation, they still did not catch exactly to the weekly response of the responders in this particular trial. When they look at the safety data comparing 50 milligrams weekly of etanercept versus 50 milligrams twice weekly of etanercept, as you can see, the serious infection rates was higher in the escalated dose group. They did not provide a p-value for that comparison, and as you can see, there was also a numeric imbalance with regards to myocardial infarctions. Now, with regards to adalimumab, the FDA-approved dosing is 80 milligrams, as we know, at week 0, and then 40 milligrams every other week, starting at week 1. So there is a trial that looked at this type of dose escalation where one could potentially consider using 40 milligrams of adalimumab instead of every other week to weekly. Let me just ask the audience, how many of you have used 40 milligrams weekly of adalimumab to treat your psoriasis patients? Yeah, so quite a few of you. And I think a lot of clinicians have become more comfortable with regards to off-label dosing of these medications. So in this particular trial, they started out with about 150 patients, and they randomized them into 3 groups. And they're placebo, adalimumab at standard dose, or adalimumab at the escalated dose of 40 milligrams weekly for maintenance. They collected their primary outcome at 12 weeks, and then they continued the trial. I shall say that at 24 weeks, those that have crossed over from placebo to the standard dose and those in the standard dosing group, if those patients have PASI less than 50, those patients can then join actually the escalated dose. So there's this one caveat here. At week 24, these patients in the first two groups could escalate their dose to weekly. So what did the data show? As you can see here, so here is your placebo, and the gray bar here represent 40 milligram every other weekly, and every other week dosing, and then the dark bar here, the black bar here shows weekly dosing for psoriasis. Now, I shall point out that in this particular case, these do not separate out the responders versus non-responders, because these are all comers, and they wanted to randomize them into placebo every other weekly and then weekly. As you can see that despite of this large difference initially, over time, the difference between the weekly and every other weekly, there's a difference there, but it's not notably different between those two groups. And here is a mean percent improvement PASI longitudinally across time. As you can see here, again, there is a difference visually between those who receive weekly dosing versus every other week. However, this difference was not significant. They did have 20 patients that had been receiving every other weekly dosing that went to then weekly dosing. So these are the non-responders. And in those patients, the mean percent PASI improvement after 8 weeks, going from every other week to every week, was 27%. So something that I tell my patients is that if we do start adalimumab and they're not responding, we could potentially consider doing every week dosing instead of every other week. And their severity may improve by about 27 to 30%. Now let's take a look at safety data with regards to dose escalation in adalimumab. As you can see, they're pretty comparable with regards to the safety data. I did want to point out that in terms of cardiovascular event, they found 2 cerebral vascular accidents, so 2 strokes, one of them resulting in death in the 40 milligram every week group, and CV events were not reported in the every other week group with this particular study. Now let's take a look at off-label dosing in terms of dose escalation for infliximab. How many of you prescribe infliximab regularly to your moderate to severe psoriasis patients? Okay, so not too many among this audience here. So the FDA-approved dosing for infliximab is 5 mg per kilogram at week 0, 2, 6, and then every 8 weeks thereafter. And it's administered as IV dosing. So one of the questions the investigators had was, what if you increase from 5 milligram per kilogram to 10 milligram per kilogram? Would you get an added response? So they took 33 patients with moderate to severe psoriasis and they randomized them into 3 groups. So this is a very small study, as you can see here. And they looked at the percent responders to the PGA score of good, or excellent or clear, which is not your typical description of a PGA score. However, what they saw is that few things that you notice. One, they had a pretty high placebo rate of 18% for a PGA score, but again, this is not your typical PGA score. In the standard dosing here, they had 82% response to the PGA score of good, excellent, or clear. And in the escalated dose, they had a 91% response to that PGA score, which was not significant. And when they look at PASI 75, which was their secondary outcome, as you can see here, they actually had a lower percentage of people achieving PASI 75 when they used that outcome for assessing efficacy in the 10 milligram group. And as you can see here, with regards to percentage improvement in PASI, the two tracked very closely. So it appears that in moderate to severe psoriasis patients, when you take that group as a whole, based on this small study, that there was no significant added benefit if you went from 5 milligrams to 10 milligrams. And in this small study, as you can see here, the safety data was pretty similar. But again, I want to caution against the small size of this particular study. Now, for ustekinumab, how many of you, just by show of hands, have prescribed ustekinumab? Okay, so a large proportion of you. And in the United States, the FDA-approved dosing is 45 milligrams for those weighing 100 kilograms or less, and 90 milligrams for those weighing greater than 100 kilograms. And their dose, as it's stated here, at week 0, 4, and then every 12 weeks thereafter. So one question is there evidence showing that perhaps shortened dosing interval of ustekinumab could potentially help with efficacy? So there's data on that. So the ustekinumab 2 pivotal trials are Phoenix 1 and Phoenix 2 trials. In fact, the first 2 parts of those 2 trials are exactly identical. The question about dose intensification is answered by the 3rd part of the trial of Phoenix 2, which I'm going to go over here. In the Phoenix 2 trial, they randomized people into 3 groups initially. So this is not weight stratified randomization in the beginning. So they took everyone, regardless of their weight, stratified them into ustekinumab 45 milligrams at week 0, 4, then every 12 weeks, and then 90 milligrams at that interval, and then placebo for 12 weeks. And then after that, they continue the trial. At week 28, those who are partial responders, so those who got PASI, achieved PASI between 50 and PASI 75, those participants, they randomized them into 45 milligrams every 8 weeks or 45 milligrams every 12 weeks. They did the same thing with those that were initially randomized to the 90 milligram group. So if they become a partial responder to the 90 milligram group, they got randomized to then 8 weeks or versus the standard dosing of 12 weeks. So what did they see? Well, they saw that in the 45 milligram group, it didn't make too much of a difference actually if you shorten the dose injection interval. So what they saw was that in the 45 milligram group, comparing every 12 weeks to every 8 weeks at week 52, that was pretty similar. In fact, you may look at this graph and say, well, it looks like the every 8-week dosing even may have performed a little bit inferior to the every 12 weeks. And I'll come back to that. In the 90 milligram group, what we saw is that in those who are dosed every 8 weeks, as you can see here, there was a significant difference between those who are dosed 8 weeks versus 12 weeks, in that the 8 weeks did result in greater efficacy. So in the 90 milligram group, if you dose 8 weeks of the partial responders, you can get almost 70% of them achieving PASI 75 compared to the partial responders that were receiving 12-week dosing. Now, there were no differences that were seen in the 45 milligram group. So the point that I wanted to go back to was that the patients, initially, they were not weight stratified at the very beginning. So the proportion of patients that were non-responders in the 45 milligram group were probably the heavier ones that needed 90 milligrams to begin with. So by shortening that dose duration, they probably didn't see a difference because those patients likely needed the 90 milligram injection in the first place. So what they saw in terms of the safety data was pretty similar between the 12-week dosing versus the 8-week dosing. With regards to the anti-drug antibodies, they found a rate of 5.4% of anti-drug antibodies overall. However, the anti-drug antibodies were significantly elevated in the partial responders compared to those who had responded completely to the PASI 75 outcome. So when we think about dose escalation and dose intensification, here's some of the considerations as follows. In etanercept, when we consider going from 50 milligram weekly to 50 milligram twice weekly, you could potentially get an improvement with regards to percentage of patients achieving PASI 75 from 27% to about 44%. In adalimumab, you could also dose intensify from every other week of 40 milligrams to 40 milligrams weekly among your responders. And you can improve the mean by mean PASI by about 27%. Infliximab, if you take all comers, it doesn't seem to make a large difference whether you're giving them 5 milligrams versus 10 milligrams based on a very small study. And for ustekinumab, typically, if you have a patient who needs 90 milligram dosing, and then you go from 12 weeks to 8 weeks, you can actually make a significant difference with regards to their efficacy. And I just presented the data that underlie these suggestions. We're going to switch gear a little bit, and we're going to talk about combination therapy. With regards to combination therapy, for this talk, I'm going to focus on combining biologic with a different type of therapy. This is because even with our biologic patients, you will probably notice that some of them still do not achieve optimal benefit from their biologic therapy. So we're going to talk about biologic combination with phototherapy, with methotrexate, with acitretin, and with cyclosporin. The key point for this part of the talk is knowing that large control studies are lacking. So a lot of these studies are either very small pilot studies or really case series of observations. Phototherapy. I just want to show this actually for the rheumatologists in the audience with regards to sort of depth of penetration of UV radiation. In general, when we think about phototherapy and think about essentially radiation here in general, the longer the wavelength, typically the deeper it penetrates in the skin until we get to 1200 nanometers. So here is typically UVB, average UVB length, and when we talk about narrowband UVB, depending on the company really, it's usually between 311 nanometers to 313 nanometers of UVB, and then here's the UVA penetration. So the most data with regards to combining biologic with phototherapy is in etanercept. The first one that I'm going to show you is a single arm study where they essentially took patients with severe psoriasis with PASI 15 or greater, and essentially these 83 patients, they received etanercept 50 milligram twice weekly, plus concurrent narrowband UVB 3 times a week for 12 weeks. So this is a standard startup dose for etanercept in the United States, and then you add on narrowband UVB. So what do you see? You see about a quarter of them achieving complete clearance that achieve PASI 100. You see more than half of them achieving PASI 90, and 85% of them achieving PASI 75. So these are definitely greater efficacy than what you see from the phase 3 etanercept trials. How about in our obese patients? So this next study addressed the question of would added narrowband therapy be helpful in our obese patients? So what they looked at was actually comparing etanercept 50 milligrams weekly versus etanercept 50 milligrams weekly plus narrowband UVB in about 30 obese patients. And obesity here defined as BMI greater than 30, which is consistent with most of the literature. So they follow these patients. So all patients initially received etanercept 50 milligrams twice weekly for the standard starting dose for 12 weeks. And then they essentially randomized them into 50 milligrams every week monotherapy, which is their standard dose, or 50 milligrams every week plus phototherapy. So what did they find? Well, unfortunately, it appears from this study that in obese patients, that adding phototherapy during the maintenance phase did not seem to make a significant difference. So when you look at 50 milligrams of maintenance dose plus UVB, you have about 53% of patients achieving PASI 75 compared to etanercept alone. How about adalimumab? Combining adalimumab with phototherapy. What they found in the single-arm study is that of 20 patients, you do your standard loading dose plus the maintenance therapy, then you add on narrowband 3 times weekly. Here, you have half of the patients achieving PASI 100, you have 3/4 of the patients achieving PASI 90, and 95% of the patients achieving PASI 75. So as you can see, pretty good efficacy here for combining adalimumab with the narrowband. And then lastly, with regards to ustekinumab plus phototherapy, what we see here is essentially, so what we see here is a reduction, here's your PASI, mean PASI, and then the reduction in terms of PASI score. This is a split half-body study, and it's only 6 weeks. During the first 6 weeks is when they gave narrowband phototherapy. So essentially what you can see is that in the phototherapy group that's combined with ustekinumab, you do see a greater efficacy in the combination group compared to ustekinumab alone. This is where they stopped phototherapy, as you can see here. Then it really caught up with regards to the efficacy, as if you didn't use phototherapy anymore in 12 weeks, they were about the same as if compared to people who never used phototherapy. So some of the considerations are as follows, is that combining phototherapy with biologics could result in greater efficacy than monotherapy with etanercept or adalimumab. But the addition of narrowband did not seem to significantly improve efficacy in obese patients. Now, biologics versus methotrexate. So for the dermatologists in the room, I wanted to see how many of you typically use biologic as monotherapy in treatment of psoriasis patients. Okay, how many of you typically use biologic plus methotrexate when you first start? Okay, so where I would say most derms in the United States tend to use biologics as monotherapy, and then if they find that to be not helpful, then add methotrexate. But let's look at the data with regards to this biologics plus methotrexate. So this is probably the largest study that looks at comparing etanercept monotherapy versus combination etanercept with methotrexate. So patients were essentially randomized into those two groups. Here are what we see with regards to the percentage of patients achieving PASI 75. So this is the combination group, and the methotrexate that they gave in this group, as you can see, the dosing is here. So 7.5 milligrams per week for the first 2 weeks, then 10 milligrams for the next 2 weeks, and 15 milligrams thereafter. And here is etanercept alone. This is all with starting the FDA-approved dose. So essentially what they saw is that at week 24, you have 60% in etanercept alone group versus 77% in the combination group. So about a 17% difference in terms of the percentage of patients achieving PASI 75. How effective is this etanercept methotrexate combination in patients with inadequate response to methotrexate? So what we see here is a clear benefit with regards to actually continuing methotrexate. So they compare etanercept plus continuous methotrexate versus once the patient is started on etanercept, methotrexate is tapered over 4 weeks. So what we see here are patients who have etanercept added on to methotrexate, but then they taper the methotrexate off within 4 weeks. And then here are patients who started on etanercept but continue methotrexate with regards to their achievement of PGA of clear or almost clear. So as you can see, a large difference here between the two groups. In the IMPACT-2 trial, I'm going to switch gear to a little bit. thinking about infliximab plus methotrexate versus infliximab monotherapy. Now, I have to say, impact looking mainly at psoriatic arthritis patients, so interpretation of some of the data, of the skin data needs to be considered a little carefully. So essentially what they did was that they looked at the PASI with regards to patients who had been on monotherapy compared to those who had methotrexate as part of their regimen. As you can see, not too much of a difference with regards to efficacy there. So several considerations with regards to combining biologics with methotrexate. Number one is that oftentimes we can think of this in patients where the desired efficacy is not achieved with monotherapy alone. Potential benefit include reduction in immunogenicity, which I'll talk about in a little more detail in the next slide. Data clearly shows that etanercept plus methotrexate is more effective than etanercept alone, and you can tell your patients it's about 17% of patients who would actually have gained PASI 75. And then infliximab may result in some additional efficacy, but very limited data. So one of the key questions, I feel like as dermatologists that we would like to answer but don't have a lot of data on is that can methotrexate reduce immunogenicity of biologics in psoriasis patients? Perhaps one step back is, or do patients respond differently, or do the drugs act differently with regards to their immunogenicity in different patient populations? So as we know, anti-drug antibodies depend on several things. One, timing of the sample taken relative to the drug. So for example, if you took the sample for your ADA testing close to the dosing administration, you actually may not be able to detect it as well because of the interference from the drug. And also the type of assay that are used, whether it's ELISA assay, which is the one that's typically used, or this RIA or the radioisotope immunoassay, which is thought to be more sensitive and more likely to detect a particular type of antibody in the population. So while we have more data, much more data with regards to RA and other rheumatological conditions, in psoriasis patients, the data is really minimal, and therefore leading to this unclear answer whether adding methotrexate may prolong drug survival in this population if you think that different populations will respond differently with regards to immunogenicity. The example I would say is that, for example, etanercept is thought to be less immunogenic than the monoclonals. However, etanercept is administered more frequently, and which may actually create this drug interference that I was talking about earlier. So, because the neutralizing antibodies to etanercept, some people think is none or much lower than the monoclonals. So, should the strategy in your etanercept patients who don't respond to standard dosing be increasing their dosage or to add methotrexate? Just food for thought. How many of you have combined biologic with acitretin? Okay, so not too many here. So I'm glad Dr. Jasondi had raised his hand since he did the study here. And he looked at etanercept plus acitretin versus etanercept alone versus acitretin alone. So what's interesting about this study is that the dosing of etanercept is different. So as you can, so the combination of etanercept is etanercept 25 milligrams every week plus oral acitretin at this dosage. And the etanercept monotherapy is 25 milligrams, but twice weekly, versus, and then here's the oral acitretin dosage. So what he found was that in patients who had combination therapy of etanercept 25 milligrams every week with the oral acitretin had almost the same efficacy as those on etanercept monotherapy, but 25 milligrams twice weekly. So potentially this combination could actually reduce your use of etanercept if that's a concern to you. And I think this result is quite interesting. So that's basically about the literature in this area. There's not a study in adalimumab or the other, or ustekinumab or infliximab with regards to this combination in psoriasis patients. And lastly, we're going to talk about biologics and cyclosporin. So this data is interesting because when you think about, well, biologics, it's immunomodulatory, and so is cyclosporin. Could that combination further immunosuppress our patients? Well, in this study by Dr. Yamauchi et al., what we saw is that they had done this combination as a transition. And they transition off cyclosporin essentially every 2 to 4 weeks with this dose reduction. So every 2 to 4 weeks, they would start actually with 200 milligrams of cyclosporin twice daily, and they saw if the patient maintained response at that rate, then they decrease it to 100 milligrams per day, and then so on and so forth. And what they found was that that was quite effective with regards to using this as a transition before patients go on monotherapy. And there's a case series looking at adalimumab as well. And what they found was also that this cyclosporin plus biologic transition state was between 6 to 11 weeks. And that seems to be a good way to taper patients. So with regards to biologic and cyclosporin combination, it can be a good option in patients who are very refractory to therapy that you started them on cyclosporin but want to get them off. So in summary, I think we talked about all of these different points. I do think that larger control studies are needed and safety data are needed to explore really these off-label and non-standard dosing options. Thank you.